Contains tropicamide with phenylephrine.
Phenylephrine. Okay. What is phenylephrine?
It's a sympathomimetic agent, madam.
Yeah. So what can happen?
It will cause
What are the conditions where this phenylephrine drops? It's 2.5% phenylephrine drops, which is used for the mydriasis to dilate the pupil. So if you're not being careful about the amount of phenylephrine that you use, you're definitely going to have other problems. So what are the contraindications for the use of phenylephrine drops in a patient?
can lead to adverse cardiovascular effects, madam. Phenylephrine.
Like what?
Uh, can lead to reflex bradycardia with not it will cause increase in blood pressure without tachycardia, reflex tachycardia.
It can produce hypertension, right? It can produce hypertension, right? Yeah. So it is contraindicated in
non-hypertensives and
yeah, in patients with uncontrolled hypertension, in patients who are on ischemic heart disease, and in very young children, in preborn and preterm children, newborns, and those are the because they come. What kind of if it's a cataract for an old age like ischemic heart disease and other things, it's different. But if you're doing cataract for a child, then it's going to be different, isn't it? Anesthesia for cataract surgery does not include only old age. It also includes congenital cataract. Now we are not going to ask for any congenital cataract problems because we are dealing with a patient who's a old person who's got a ischemic heart disease or whatever, coronary artery disease. But if you're dealing with a child who has a congenital cataract, the anesthesia that you give will be entirely different, isn't it?
Yes.
Yeah. So what do you do if it's for a child? Kamakshi, I'm just occupying them till sir comes. That's all. As soon as sir,
Yes, ma'am. Yes, ma'am.
Yeah.
Patriotic of choice differs, madam. Here we can use atropine.
What anesthesia will you give for the child?
Anesthesia, we prefer a general anesthesia over regional in children.
Definitely general anesthesia is always given, right? Not regional. It's only for a cataract in old age that we do as a daycare procedure. And of course, you can do daycare even with the general anesthesia for a child, that's different. But here it is done under local usually. And what is the type of anesthesia that we give? What do they call the anesthetist there? If they want to do it completely under local, why are there so many ophthal anesthetists?
Complicated.
You can have complications, so you want the anesthetist there to handle the complications, right?
Can
we do something else?
Require extra monitoring.
Okay, monitoring. Okay. Do we give anything else? Can we sedate the patient?
Yes, madam. We can sedate the patient before surgery with sedatives and.
What is it called?
Monitor anesthesia.
It's called twilight. Twilight. No.
Twilight.
They have one thing. It's called twilight anesthesia. What's the difference between twilight and general anesthesia? Like you have in the dental also, you have what is called conscious sedation. No, you have conscious sedation anesthesia for dental procedures on the dental chair. Conscious sedation. That's another short notes actually. Conscious sedation on the dental chair. That's another short notes. So those are also, they have lot of ifs and buts and don'ts and everything. So like that, if you want to give sedation for a patient who's got cataract, coming for cataract surgery, what would you like to give? And what do you do when you give a sedation like that? It can be 85-year-old man, it can be a 90-year-old man. They may not even lie down on the table. They'll get restless. You could have Alzheimer's. So many things will happen.
It doesn't.
What can happen?
apnea, they are more prone for
Okay.
respiratory depressions.
Mm.
Lying down by an 85-year-old man can precipitate.
Sometimes the effect that you give, suppose you give a 1 milligram midazolam, the effect that is happening to that age in that particular thing, when they come for cataract surgery, cannot be sometimes be predicted. Okay, it becomes difficult. It can be unpredictable. So you have to monitor them much more closely than you would monitor a normal 40-year-old person. Okay, so suppose a patient is coming for dental extraction and he's just 30 years old. He's got nothing else, and you're doing under conscious sedation in the OP. Then you can boldly give 1 milligram, 2 milligram, even 3 milligram midazolam without any problem. Whereas if you're doing it for a 85-year-old or a 90-year-old, it's not as predictable. So we have to be very careful about using it. Okay. All right. Okay. Then of course they're going to ask you about the blocks that you can give for cataract surgery, and about each block. What are the blocks that are given recently? In recent times, what blocks do they give?
Sometimes peribulbar blocks.
Peribulbar they're giving, retrobulbar are they giving? What are they doing now? Recently,
within the cornea, they can give, madam.
What is it called? Topical.
Topical drops can be given, madam.
Topical analgesia itself is.
The cameral opening the cornea, they can spray a little amount of lignocaine and then anesthetize.
So totally the amount of lignocaine that you're using has come down drastically. Earlier days, they were using retrobulbar, then they came to peribulbar, and now they're using topical analgesia itself, right? Yeah. What was the difference between cataract of surgery of yesteryears and the cataract surgery of recent times?
Cataract surgery yesteryears we used extracapsular extractions, madam. Now we are using.
Yeah, it is mature cataract. It has to be a mature cataract, and only then they'll be able to remove it. Whereas now we don't want it to be mature. We want it to take it as a thing, because what they're doing now is phacoemulsion. Yeah. All right. Okay. So you will have to answer, sir, about all the blocks and all that. I'm sure he's going to ask you. And then he's going to ask you about the systemic effects of local anesthetics if it is injected last, local anesthetic systemic toxicity, and then sedation, and monitoring a patient during cataract surgery. So this is all the thing that you need to know when you talk about cataract surgery. Okay, let sir come, and then we'll ask the rest of the questions.
Yeah. Thank you, madam.
I have joined. Thank you.
Okay.
Good evening, sir.
Yeah, good evening. Am I audible?
Sir, just so chuma occupy
I know. Thank you very much for. Okay.
Good evening, respected Nagasamy sir, Professor Rasni madam, Professor Selvamani madam. Dr. Kalpana has joined from Beach Candy Hospital, Bombay, and Dr. Sushil Krishnan from Northern India Central Hospital. And dear students, I welcome you all for our RAISA DNB online academic activities today. Today, we will request Dr. Mobeen to start with this first case presentation. It's a case of CAD coming for cataract surgery. Over to Dr. Mobeen.
Good evening, sir.
Good evening, Mobeen. Are you able to hear me?
Yes, yes, sir. Able to hear.
Okay.
Today I'm going to present about my patient who is a 67-year-old male patient by name Mr. Murali, who is a trackman by occupation, coming from Kolattur. Presented with the chief complaints of blurring of vision on the left eye for the past 1 year, and seeing a double vision and glare from bright light in the left eye for the past 2 months. Coming to history of presenting illness, he was apparently normal 2 years ago, following which he developed blurring of vision more at night and evening, associated with and also double vision and glare from bright light for the past 2 months. There is no history of any excessive watering of eye pain, eye swelling, loss of vision, conjunctival swelling, conjunctival redness. The patient is a known a patient with coronary artery disease, diagnosed 2 years ago, where he developed chest pain on walking stairs, following which he was admitted in medical ICU and managed medically. No interventions were done. No invasive interventions were done, and presently he is on medications with metoprolol 50 mg PD, ecosprin 75 mg OD, atorvastatin 10 mg in the night, and enalapril 2.5 mg PD. Currently, there's no history of pedal edema, shortness of breath, or difficulty in day-to-day activities. I missed one small history, sir. That chest pain, it was actually relieved with rest, and then some tablets were given that he kept under his tongue, probably sublingual nitroglycerin. Following this admission, he was advised to undergo coronary angiogram, but he refused. And this is the history of the patient. There is no past surgical history. Coming to personal history, is known he was an ex-smoker who stopped smoking for the past 2 years and also used to regularly consume alcohol for the past 15 years, but stopped 2 years ago. He has normal bowel and bladder habits. There's no history of any drug allergies in the patient. This is my short history.
Something is coming. Preeti is starting to share the content. Kamakshi? Hello?
Sir?
Mubin?
I'll stop it, sir.
Yeah, okay. Number,
Sir?
continue, Mubin. There was some interruption.
This is a short history of my patient. Coming to summary, a 67-year-old male patient with complaints of blurring of vision and double vision with glare to bright light on the left eye.
Is it blurring or is it dimness of vision? Which is the correct terminology?
Defective vision, dimness of vision.
Dimness of vision. Gradually, the vision becomes dimmer and dimmer. Okay. Blurring means you are still able to see something in a hazy way. Whereas dimness means gradually he is losing the vision. Okay. So he is not able to perceive somebody. No, in those days, as Dr. Vasanthi was telling, till it becomes totally mature. We used to sit in the OP and shake our fingers and ask him whether he is able to see. If he says, even that moment I am not able to see, then we take him up for surgery. That much of blindness will be there. Okay? So dimness is the better word than blurring. But you mentioned about halo, isn't it? Or color.
Sir.
When does it happen?
Especially
does it happen at the late or night? Is it in the early stages of cataract formation or in the late stages of cataract formation?
Glaring occurs in the early stages.
Early stages, okay. That may be some of the heralding features of cataract formation. Okay? So halo in the night when seeing a bright light coming in, especially when you are driving, if you see a halo around the light that is being projected in front of you, that is the earliest sign that you are developing a cataract. Okay. Whereas when the cataract, when it becomes more and more mature, that vision is totally gone. It becomes completely absent. Okay. Right. So this is a short case scenario, but because the Viva question had a concept, a component of CAD in the question, I think Dr. Kamachi modified it and gave it as a cataract. But in the exam, mainly the questions will be about cataract per se, isn't it? So generally, what type of population get cataract?
Elderly population.
Elderly population. So within that short time given to you as a short case, what are all the important history you should like to elicit in this case? Forget about the CAD as a comorbidity here. What are the common comorbidities or important history that you would like to elicit for a person coming with dimness of vision diagnosed as a cataract, likely to undergo surgery for cataract? What are all the important points? Elderly person, let us say more than 70 years old, coming for cataract surgery, what are all the important points in his medical history you would like to obtain from him?
Sir, comorbid history, including
Very good.
diabetes, hypertension,
Okay.
in trying to, for example, use of drug history, sir, steroid
Okay.
induced.
Mm.
Then
Mm.
elderly, so
Mm. Would you like to know anything about his musculoskeletal system? Whether he has got any arthritis, cervical spondylitis problem, hip problem, knee problem, whether he can climb and get down the operating table himself, or does he require assistance for that? Do you like to ask that?
yes, sir.
That's important, isn't it? Supposing he has got a fixed flexion deformity of the neck, of the cervical spine, he
Yeah, he
cannot
cannot lie
extend
down.
his neck, he cannot lie down comfortably, and the surgeon will, what position the surgeon wants to do a cataract surgery?
Completely supine, sir.
Supine position with the head resting nicely on a support, as much as possible extended so that he can have a direct vision from above. Okay. Are they doing a cataract in any other position now? If a patient has got difficulty like this, not able to lie down, cervical spine problem, are they doing cataract in any other position in the modern days? Madam was asking about newer techniques of anesthesia. Are there newer techniques of surgery for cataract? Especially for patients who cannot lie down because of this sort of musculoskeletal or joint problems.
They may recommend position.
They are doing it in the sitting position, just like they do the slit lamp examination. Where have you ever gone to an ophthalmologist for eye checkup, or
Yes,
have
sir.
you seen slit lamp examination in your training period as an undergraduate in ophthalmic department? All of you would have come across, isn't it? So especially for those who are not able to lie down, they have devised a method where you can ask the patient to sit up, lean forward, rest their chin on the support, and they are able to do the cataract because of the advancements of the instruments and other things now. Okay. But that is not very common. But so history of ability to lie down flat, and if some people, if they have a congestive cardiac failure, what will be the problem? Even though they don't have a spine problem, if they have this patient, especially CAD patient, if he has developed some post CAD congestive failure, what will be the problem with that patient?
Breathing difficulties, sir.
He will not be able to lie down for quite some time. Okay, he will find it difficult. He may become breathless. So the question that you would like to ask the patient is, will you be able to lie flat on your back at least for about 20 to 30 minutes till the surgery gets over? Okay. Then the third thing, some people, when they cover the face, what will happen?
Anxious and hyper.
Claustrophobia. They will get frightened. They will say, I'm not able to breathe. I am finding it difficult. Take off that drape and all that, isn't it? So claustrophobia history, that also is very important. And about all the comorbidities, what are all the medications they are taking, okay? And what is the level of perception of this? And what is the
Sure.
common anesthesia we do for cataract surgery?
Regional anesthesia with blocks
Regional.
or
Who gives the block? The anesthetist or the surgeon?
surgeons mostly.
In small institutions, surgeons themselves give. So what is your role in there as an anesthesiologist?
To provide a monitored anesthesia.
Monitored anesthesia care. So you will be only providing monitored anesthesia care. But in bigger institutions, say like a leading ophthalmic, mainly ophthalmic institutions, corporate institutions, there will be anesthetists who perform the block and surgeon will just operate. But with the advent of topical, majority of the time surgeons themselves give instructions to the top. Supposing they plan to do topical, how do you have to do that? Adam was asking, this is the newer method, isn't it? Topical. So
Yes.
what drug do you use? How frequently you use? And what are the advantages and disadvantages?
Topically, we can use either 2% glycinocaine or 0.75% bupivacaine.
That is not being commonly used. Ophthalmologists use a different drug. Anesthetic only uses 2% bupivacaine and 0.75%, bupivacaine and bupivacaine, all the things. They use a different local anesthetic. The books also give that only. They use a drug called proparacaine. Okay. So proparacaine 0.5% is the drug that what is commonly used by most of the ophthalmologic practitioners. And you have to apply it right from at least 1 hour prior to the surgery, every 15 to 20 minutes, 3 to 4 drops. Okay. So that will, how does that anesthetize? What is the mechanism? It's like any other local anesthetic only. But what is the mechanism? How does it make the eye tolerate the stimulus?
So it will block the short ciliary and the long ciliary.
Nerve endings in the conjunctiva are blocked. Okay. Right. So what are the advantages of this technique?
Sir, advantages, it is non-invasive. So
Technically very easy. Even a nurse can keep on putting the drops, or the patient themselves, they can apply the drops. So technically very easy, number one.
Patient also will be very tolerable.
Patient acceptance is much better. Very good. Then anything to do with the IOP, intraocular pressure?
Less chance of manipulation or rise in IOP with the topical anesthetic.
You can avoid the increase in the IOP by giving, if you give a block, will you raise the IOP or decrease the IOP?
If the retrobulbar box will increase IOP.
It will, so you are increasing volume into the orbital cavity. Okay, so that pressure is going to cause an increase in intraocular pressure. Is there any instrument to decrease that IOP caused by the volume of drug injected into the peribulbar or retrobulbar area?
Sir?
Block. They find the eye ball is very tense. Can they do something to reduce that IOP and the tension inside the orbit? Is there any instrument for that? Have you heard of Honan balloon?
Honan balloons.
Honan, Honan balloon that is being applied. Have you ever seen that, at least in the net?
Sir, yes, no.
It's like something like a ping pong ball. Okay, that will be applied and the Velcro strap will be there and that will be tied to the forehead and the eye. And it has to be left in place for 10 minutes. What is the purpose?
To give counter pressure so that
It will disperse the solution evenly and reduce the pressure exerted on the globe and raising the intraocular pressure. Okay, so that is that all that problem will not be there if you do it topical. But what are the disadvantages of the topical block?
there will not be any akinesia. So patient will move the eyeball.
But majority of the surgeons are able to operate even there is no total akinesia. How is that patient does not that vigorously move the eye when you apply topical?
Patient will ask to focus on a point.
Yeah, but even if you ask them to focus on a point, after some time they cannot focus it. But still, if your topical is quite effective, they don't move the eye that frequently, like they normally do. What is the mechanism or what is the mode of action? It is simply breaking the reflex arc. Any muscle contraction, why does it happen?
Stimulus.
It is a stimulus from the sensory system, isn't it? It's a reflex arc. The sensation perceived goes through the sensory fibers, gets to the center, stimulates the muscle, and then the muscle contracts, isn't it? So it's a reflex. So if you break the reflex by blocking the sensory input, the muscle does not receive any stimulus. so it becomes lax. It doesn't move unless the patient himself wants to move. He will not. The muscle automatically will not move for the touch. But when you are not applied any topical, and if you try to go and touch your cornea, what will happen?
Blinking and movement.
You will try to close your eye, your eyes, the eyelids will try to close, and eyeball will try to move away from that stimulus, isn't it? So all that is not there because of the blockage of the sensation. Okay. So even though there is not total akinesia, patient will not violently move the eye for the manipulations done by the surgeon. Okay. Right. So what are the investigations you want to do before you take up a patient for cataract?
Investigations include a complete blood count, renal profile with urea creatinine and electrolytes, and that is
all elderly patients, if they have any supporting as a CKD and or CAD, what do you want to know about the cardiac status?
in minor surgeries, ECGs are not required. I think. Low risk surgeries.
Low risk surgery. So you can, supposing your block is inadequate and he develops a pain and he goes in for an acute infarction on the table, is it okay? You give the block or the surgeon gives the block and the block is ineffective and there is a intense pain. Can something go wrong?
Better to have.
So you should know at least from the records what he has consulted his cardiologist, whether there is a clearance given by them, okay? Whether he has been taking his medications regularly, what is his effort tolerance, whether he will be able to lie down flat for quite some time, all this history about the respiratory. And if supposing he has a COPD patient, what would you like to know?
COPD patient.
Can he cough in between the surgery?
No, sir, you should not cough.
Why?
Coughing can lead to rise in IOP as well as can cause injury, an inadvertent injury during.
So rise in IOP, what is the most dreaded complication, surgical complication during cataract surgery?
Expulsion of contents from.
How can the expulsion happen? That too with the modern technique of so-called phacoemulsification. What do they exactly do in that? What are the anatomical layers of the lens which develops a cataract? Anatomy of the lens.
Anterior capsule or the posterior capsule can develop along with the body of the lens.
No. What are all the anatomical structures that are there in the lens, which it becomes cataractous or develops a cataract? What exactly happens in a cataract? What is the pathophysiology of cataract?
There will be dehydration and the degenerative changes of the lens, yes, leading to water accumulation and loss of transparency.
So histologically, if you cut a lens and put it under microscope, how many layers you will see?
5.
5 layers. What are the 5 layers?
Anterior capsule.
Anterior capsule, okay. Just like the kidney, it has got a cortex. It has got a cortex which is divided into outer cortex and inner cortex. Then there is a nucleus. The important structure, there is a nucleus. Then again on the back side, there is a inner cortex, outer cortex, posterior capsule. Okay, so it is something like a oval shape. Okay, so there is an outer cortex here. I mean outer capsule or anterior capsule as they call it. Then there is a outer cortex, inner cortex, nucleus, again another inner cortex, outer cortex, posterior capsule. Okay, that is the entire structure of that. So during surgery, what do they do exactly?
They will remove up to the lens nucleus from the lens capsule, except the posterior capsule. It will
They just leave the posterior capsule intact. How is the lens held in position?
be artificial lens or
No, normal lens. How is it held in position?
ciliary muscles and
It has got a ciliary muscle attachment to the what is called the zonules.
zonules.
Okay. So it is attached above and below. So the zonule as well as the lens by itself during younger days, they are able to adjust their length so that depending upon the focal length of the objects we are seeing, it adjusts both the vertical size or it becomes bulged out like this. So it is able to do all those things. So this is a transparent structure. Is there any blood supply to the lens?
No, sir. It is usually by diffusion.
It is an avascular structure. Okay. But how does it survive? It is avascular.
The constant flow of fluid in the anterior capsule of the lens will wash away and give supply nutrition via.
So the aqueous humor that is secreted is the one which supplies the nutrient required. Okay. And the lens layer, the outer cortex, inner cortex, nucleus, what is the biochemical material out of which they are all made?
They are made up of
fat, carbohydrates, or proteins? Multiple choice. Only 3 choices.
proteins.
Proteins, naturally, they are all proteins. So during cataract formation, what change happens in these proteins?
Coagulation.
They become coagulated. Okay. Why they become coagulated?
Because the water content is decreased.
Water content. Why water content should suddenly decrease? Oxidative stress. Okay. They undergo a lot of oxidative stress. And free radical or the reactive oxygen species, they are the ones which cause these changes in them. Okay. So they undergo this transformation from a transparent protein, they become opaque proteins. So light is not able to pass through them and you develop dimness of vision, and over a period of time, it becomes quite mature, you become totally blind. So based on the anatomical or histological knowledge, how can you classify or how do the ophthalmologists classify the types of cataract?
Nuclear cataract. Anatomically.
Nuclear cataract? You are right. You have studied something in your ophthalmology, you have forgotten.
Posterior subcapsular.
Posterior capsular and capsular, I mean cortical cataract, posterior cortical and nuclear. These are the 3 types of changes. So how can you distinguish these 3 types? Can you just throw light with your torch light and identify what type of cataract it is? Whether it is nuclear cataract or subcapsular, posterior subcapsular, or whether it is a cortical cataract? It is diagnosed only by slit lamp examination. Okay. So once a patient is fit enough to undergo cataract surgery by assessing his general condition as well as the status of maturity of the cataract, what is the other important thing the ophthalmologists carry out before performing the surgery? If they plan to put an intraocular lens, foldable lens,
they will measure the length of the axial length of the.
So what is the normal axial length of the globe?
Globe 25 to 20 to 25 mm.
23 to 25 or 26 centimeter or millimeter?
Millimeters.
Millimeter. Okay. Always the unit is important. Okay. So that knowledge or the information that is written in the ophthalmology notes, is it important for you as an anesthesiologist? Supposing you are the one who is going to give the block, that is the routine in a hospital where you could join as an anesthesiologist, a big ophthalmology institution, full-time anesthetist to perform ophthalmic anesthesia. Would you like to know that information about the axial length of the globe? In what way it is concerning you also?
So the axial length is important, sir, because while giving retrobulbar block, we are
Only retrobulbar or even for peribulbar?
even peripulbar block,
Mm.
we will
Mm.
we will cross the we will try to go along tangentially along the wall of the orbit. So in that, if the axial length is to excess, like in the case of myopic eye, we will
Ah.
immediately pierce the orbit and then give the drug.
So in myopic eyes, what is the danger? What happens to the optic and the axial length, and what happens to the globe as it is?
Yeah, axial length increases, sir, and globe becomes huge.
Thinner, okay? So
Thinner.
you can easily puncture the globe, isn't it? So supposing by fault or by accident, you give a block and you have punctured the globe, how will you identify that?
There will be sudden loss of vision in the patient and a rise in IOP.
Already he has got loss of vision, he has dimness of vision. Will he complain of further loss of vision? He has come to the hospital for only correcting the dimness or loss of vision.
We will have complaint of pain, sir.
Severe pain, that is the first and foremost thing. Normally, when you give it peribulbar or retrobulbar without puncturing the globe, it will not cause that much of pain. Initial deposition will be slightly irritating, but later on it will stop because once the action comes on, it will vanish. But in a punctured globe, if you inject the drug, it goes where does it go into?
It will go into the vitreous humor.
Vitreous humor, okay? That will be very, very irritating and it will be very painful. So supposing you suspect that you have punctured the globe, how will you identify that? Patient is complaining of intense pain. So whether you are still outside the globe or inside the globe, how will you detect?
Sir, moving the needle.
Fixing the needle is there inside the orbit, that's all. You do not know whether it has gone into the globe, but patient is complaining of intense pain. Sometimes, fussy patients, even if you are totally outside the globe in a peribulbar or retrobulbar also, they can complain of pain. What other important tests that you can do to identify whether it is a globe puncture or not? Supposing you ask the patient to move the eye.
The needle will also.
He cannot move the eye because your needle is fixing the globe, isn't it? So if you have punctured the globe and gone inside the sclera is fixed there, isn't it? So he cannot move the eye normally, right? So that is another important test by which you can find out whether the globe puncture has taken place or not, right? Okay. So axial length is very, very important. So commonly we do the cataract surgery only. Preferred technique is one of the regional techniques. So starting from topical, using proparacaine 0.5% several times before the surgery, or planning for a retrobulbar or a peribulbar. What are the disadvantages and advantages of retrobulbar and peribulbar? And what is the technique of doing it?
Retrobulbar, it is initially this is the method of regional.
What is the other name for retrobulbar?
Intraconal.
Intracoronal injection. Very good. What do you mean by conal injection? Where is the cone formed?
The cone is formed with the apex in the orbital wall opening, sir. Base is around. Apex is formed in the medial part.
Which structure forms the cone? To call it as a cone.
Extraocular muscles.
The four extraocular muscles. Superior, lateral, medial, and inferior oblique muscles. Okay, these four muscles only form the cone. So they are attached anteriorly to the sclera behind the cornea, and the posteriorly they all join together to form a tendon and get attached to the bone. Okay, so that forms the cone. So if you inject the drug inside that cone formed by the four oblique muscles outside the sclera, it is called intraconal or retrobulbar block. Whereas if you give it outside the cone formed by the four oblique muscles, then it is called peribulbar block. Okay. So what is the volume required for intraconal or retrobulbar, and what is the volume required for peribulbar?
Volume required for retrobulbar is less, sir, around
Yes.
2 to 4 ml.
Mm.
Whereas for peribulbar, large amount of volumes up to 6 to 12 ml can be.
Yeah, 60, maximum 6 to 7 ml will be more than sufficient. Okay. But which is the most feared danger or complication of retrobulbar or the intraconal block?
Retrobulbar hemorrhage can occur.
Hemorrhage one. More than that, much more serious than that.
The central retinal artery occlusion
Central retinal artery occlusion. Why
or
should it happen?
puncturing of the globe is more.
Puncturing of the globe or the nerve?
Optic.
Optic nerve is there at the end of it, isn't it? So injury to the optic nerve, or sometimes you can go, and if you use a wrong needle, long needle, and puncture, and you go even through the optic foramen and inject all the local anesthetic there, where will it go?
It's going to the brain.
Intracranial. Okay, migration will be there. So there are earlier days when they were using only retrobulbar. There are reports of patients dying because of the inadvertent puncture of the dura and depositing the solution into the intracranial compartment. Okay, so puncture or injury to optic nerve, intradural injection, or major retrobulbar hemorrhage. These are the three major complications that can happen with retrobulbar block. So nowadays people don't prefer to use it. So peribulbar is much safer compared to that because you are depositing all the solution outside the globe, outside the cone. So that is much more safer. Okay. What is subtenon's block, which is very widely practiced in the Western world?
Given underneath the Tenon's capsule.
Where is this Tenon's capsule? How is it done? What is the technique of doing subtenon block?
The Tenon's capsule is a fibrous layer here of elastic tissue formed from the formed around the sclera, in the posterior sclera, and gets attached to the posterior part of the globe. So it is has some potential space, especially the posterior part of the sclera. So what we do is we make a small incision over the conjunctiva, some 1 to 2 millimeter size, and then we use a curved needle tip. Then we give the drug in between this between the sclera and the Tenon's capsule, known as subtenon space. It will spread along the subtenon space and then diffuse into the retrobulbar space and block.
So what is the volume required?
Here also volume is much lesser, around actually 1.5 to 3 ml can be.
Yeah, maximum 1.5 to 2 ml will be sufficient. And the procedure you said is right. You have to make an infromedial cut in the conjunctiva, that is closer to the nasal side. So you make an infromedial opening in the conjunctiva using what is called a Westcock's forceps. Okay, and then elevate the subtenon's capsule and make a nick onto that also, and you can use a special cannula that is available for that, or even use a 22 gauge Venflon and introduce it around to that for about a millimeter or two and inject about 1.5 to 2 ml maximum. That will produce beautiful anesthesia for the entire eye. It will produce good akinesia also because the drug will spread over the muscular sheath and make them immobile. Okay, so this is the technique preferred mostly in the Western world. So most of the time we prefer to use only the regional technique, but are there indications for giving GA for this surgery or cataract surgery? And if so, what are the indications?
Indications for general anesthesia and cataract surgery is usually congenital cataract surgeries.
So it is
The patient population is difficult to manage in a local, as well as those
pediatric patients. Mostly
pediatric
they will be pediatric cases. Okay.
Yes,
Which
those
of the adult patients who may require GA?
who are mentally challenged.
Okay. Adults who are
And
very much
also
scared, apprehensive
Cataract
about
Parkinson
regional
is
technique, not willing to get it done under local, refusing to have local anesthesia, or
shiver.
patients who cannot lie down for a long time. So all these patients may require general anesthesia. So if you give general anesthesia, what are the precautions you have to follow? Or what are the important
In case of general anesthesia, use of induction agent method should be followed to
what is
avoid
the first tip to difference between regional and the GA for cataract?
uh,
Do you ask the patient to come in starvation when you want to do it
no,
under topical or local anesthesia? Do you say the absolute starvation is essential?
it's, you can done absolute starvation is not required.
Not necessary. So when you plan it on regional technique, you don't ask the patient to completely starve. You can say you can have a light breakfast, you can have your morning coffee, no harm, but don't eat anything at least half an hour to 45 minutes before the surgery. In case you feel nauseous or anything, that may be a problem. That's all. So there is no need for absolute nil per mouth. Whereas if you plan for GA,
As an NPO status,
all the NPO instructions have to be carried out, number one. Okay. Then,
pre-medications can be required in
okay. You only said it's a small surgery. So what pre-medication you want to give? Is it a daycare procedure or a admission
daycare
procedure?
procedures.
So if it is a daycare procedure, you must recover the patient as quickly as possible and send them home, isn't it? So if you plan to give GA, how are you going to make them recover faster and make them roadworthy and send them home?
Usage of short-acting agents preferred, sir. Especially and use of atracurium over vecuronium preferred. Avoiding the use of scoline and instead of that rocuronium if rapid sequence integration is required is preferred, and ketamine should be use of ketamine
So
should
you
be
must go in an order. You should say what is your induction agent, whether you want to paralyze and control the ventilation or whether you want to leave the patient on spontaneous, because it's after all 20 to 25 minutes procedure. So what are the advantages of controlled over spontaneous? If it is spontaneous, what is the volatile agent of choice? How are you going to manage? If it is controlled, what is the relaxant of choice? If it is going to be, whether can you use dexamethasone for intubation? Okay, this is how you should discuss these points. And what is the analgesic that you are going to use? What are the intra-op and post-op complications of GA for eye surgery? This is how you have to discuss. So starting from the induction agent, which is the preferred induction agent?
induction agent with propofol is preferred.
Propofol, because you want to send the patient home the same day within after say 2 hours or 3 hours of recovery. So propofol will be the best ideal agent for induction, right? Okay. What about whether you want to put in a tube or LMA or whether you want to which one airway management? How are you going to do? If it is
I will
LMA, what
prefer
is the?
I will prefer use of supraglottic airway, sir, because the risk of rising IOP is minimal with avoiding endotracheal intubation.
Very good. Okay. But what is the what type of supraglottic airway device you require for this surgery, and what is the other disadvantage of using a supraglottic airway?
I will prefer to use Prosil LMA, sir.
Prosil LMA. Okay. Prosil LMA, don't you think it is very stiff and it will be projecting when the surgeon tries to drape the face?
Yes, sir. It will be stripped enough.
So will the surgeon be happy with that? Any facial surgery, surgeons probably want the tube to be flattened out at the chin. It doesn't stand up and form a dome when they drape the face, isn't it? So what is the option you have for that?
South facing raised tube can be used.
Yeah. That is ray tube means it becomes intubation. Is there any supraglottic airway which is available which can be bent without causing a projection? We have flexometallic supraglottic airways, isn't it? Have you seen that? So the classical LMA version was introduced with a flexometallic conducting tube, mainly for tonsillectomy surgeries. Okay, that will be an ideal one so that it can be bent and fixed onto the chin so that it doesn't project out. In case if you want to secure the airway by endotracheal intubation, as you said, a south facing or the oral ray tube will be ideal tube for all the ophthalmic procedures, right? Okay. So which one would you prefer? Spontaneous respiration with inhalation of volatile anesthetic agent, or would you like to paralyze and control the ventilation?
I would prefer spontaneous ventilation.
What are the advantages and disadvantages?
Easy recovery and early post-op discharge is possible with spontaneous compared to paralytic use of paralytic agents.
But what is the disadvantage? Supposing patient is
can buck and cough and then tube.
Can hypercarbia happen? Can the tube, if it's a supraglottic airway, can it get dislodged?
Yes. Coughing, bucking is possible, and dislodgement of both the ET tube as well as supraglottic airway is possible. And
so because the face is going to be completely draped, it is always safer to go for a endotracheal intubation so that you be confident that the tube is in the airway. Okay. So unless you are very experienced in supraglottic airway usage, you have to better go for endotracheal intubation with a south facing or a oral cuffed ray tube so that you can have a control over the airway. And if you control the ventilation by paralysis, what is the advantage? Can you manipulate the IOP?
Yes, sir. IOP will fall down.
It is more or less like managing the intracranial pressure. Okay. In neurosurgery, whenever you want to decrease the intracranial pressure, ICP, what do?
We will increase the plane and as well as paralyze the.
No. During controlled ventilation, in intracranial pressure, if it is,
we will increase the carbon dioxide.
You will increase the carbon or decrease the carbon?
Carbon dioxide washout.
Hyperventilation. You try to decrease the CO2 level by mild to moderate hyperventilation so that you bring down the CO2 to EtCO2 to 30 millimeter. Okay. So the same thing can be done for reducing the intraocular pressure also. Same principles apply. Okay. So control ventilation has that advantage, and you can maintain a lighter plane of anesthesia and get the patient out quickly, roadworthy, without any residual drowsiness. Okay. So what is the most important care you have to take during GA for the surgeon to prevent that complication of vitreous prolapse? They are going to open the cornea and then meddle with the lens and all those things. So IOP should not become high. Intraocular pressure should not become high. What is the normal IOP value, intraocular pressure value?
Can range from 8 to 12 mmHg.
Very good. So how is it maintained at that level? What are the factors controlling the intraocular pressure?
The flow of aqueous humor in trabecular meshwork filtration, and also the contraction and the external pressure applied by the extraocular muscles. Third is lens.
Do the surgeons give any pre-treatment to prevent the rise in intraocular pressure?
So they can give acetazolamide or mannitol to raise.
Ah, yeah, very good. So they give oral tablet of acetazolamide for local anesthesia also. Okay. So same thing. Is it available as parental preparation, acetazolamide?
Acetazolamide, eye drops have been seen, sir, and oral tablets.
Okay. So that is also a third of reducing the IOP. Okay. So these are all the points that have to be remembered with regard to cataract, right? What are the post-op, how intra-op analgesia during GA? How do you manage that? Would you like to use fentanyl, or would you go for non-opioid or opioid-free anesthesia, analgesia rather?
Opioid-free analgesia with either paracetamol or
Mm.
tramadol can be tried, sir, because the effect on respiratory depression is much less.
Okay, more than respiratory depression, what is the other important complication after eye surgery you would like to, especially in children?
Bradycardia.
Bradycardia is strabismus surgery is very common. That is squint surgery. That's where you get bradycardia because of the oculocardiac reflex. But in cataract, do you get the same reflex? Not normally. Nausea and vomiting is very common to all eye surgeries, whether it is cataract or whether it is strabismus surgery. In children, any eye surgery is more prone to result in nausea and vomiting. So you want to avoid any drug that is likely to induce nausea and vomiting, like your fentanyl or opioids.
Even
Can you give a supplemental block after GA?
yes, sir. We can give.
Yeah. So the multimodal technique of analgesia is you can give a block after inducing GA, and you can use non-opioid drugs for analgesia both intra and post-operatively. Okay. So what are the precautions to be taken during recovery after GA for eye surgery, especially cataract surgery?
Precautions.
Already said bucking and coughing, all these things should not happen, isn't it? Just like in intracranial pressure case, here also you don't want any bucking and coughing. So you have to do a smooth extubation. So what are the drugs that are available to produce a smooth extubation?
Lignocaine can be given 90 seconds before extubation, sir.
Very good. Any other drug which is available now and which is very commonly used? Any dexmedetomidine. Dexmedetomidine also is one of the drugs which is commonly used to tolerate the tube and produce a smooth extubation without. But of course, it has got some of its own disadvantages. What are the disadvantages of using dexmedetomidine?
Hypertension and especially bradycardia.
Bradycardia and hypertension. Okay, so these are the things that you have to remember with regard to cataract. Okay. So I think any other questions? Anything else? Vasanthi, are you there? I think it is not there.
No, sir, madam is not there.
Okay, right. Okay. So any questions from anybody? Any doubts? Because this is not a commonly, most of you may not get a chance to see these cases or do these cases during your training unless you are specially posted in the ophthalmology department. Majority of the students do not have an exposure to these sort of cases. Okay. So, but these cases are nowadays kept in the exam as a short case. So these basic points, at least you shouldn't be able to answer. That is the reason why this question has been included in today's discussion. So, okay.
Short cases, do we need to present as a complete history, sir, or only for challenge?
No. Depends on the examiner and the time. They will give you the diagnosis. They will ask you what anesthesia you will give. So straight away go for that without
Yeah.
asking for pre-op examination, investigations like that. And they may just ask a few questions about which is the better type of block, what are the advantages, like what we discussed here. But if they have a lot of time, they may ask you, but the pre-op points like an elderly adult not able to lie down or having a difficulty in lying down due to the musculoskeletal or cardiac issues, that is a very, very important point. Similarly, a COPD patient having a chronic cough who will be coughing all the time is also another issue which you have to find out and know. Otherwise, midway through, if they get into problem, you cannot stop the surgery, especially if they have started doing the phacoemulsification and patient says, I am not able to lie down. How will you proceed? So that is a very important history you have to find out from the patient. Okay. So they will not meddle you much, but short case presentation and answering is depending upon the time and the mood of the examiner. They may straight away go to the question, ask you a few questions and finish it off. Or if they have a lot of time, they can start from the history taking and then go on to the individual steps also. So it depends on how the timing goes there. Hmm?
Somebody asking, sir?
Somebody was asking something, I can't comprehend what they are asking.
If no questions, shall we move on to the next presenter, Dr. Preeti?
Yeah.
Go to Dr. Preeti.
Yes, sir. I presented the case of ECT.
Your slides are not visible. You are planning to project a PPT.
So, my topic is 32-year-old pregnant female patient in her third trimester receiving tricyclic antidepressant scheduled for modified ECT. How to do the anesthesia management. So, I have taken one case.
Hmm?
So 32-year-old female patient standard abandoned by her husband, came with 7 months of amenorrhea to hospital with his stepmother with chief complaints of irritability on trivial issues, abusive behavior, passive death wishes since 7 days. And the patient has deteriorating course in 7 days and spanning since 6 months, and with the index episode. She has same episode 6 months back also. Then no cough, cold, fever, PV leak, bleeding, breathlessness, pedal edema, headache, chest pain, blurring of vision, nausea and vomiting. Then history of present illness. Patient was apparently all right 6 months back when she developed low mood, decreased sleep. She had episode of fall and used to faint without apparent reason. These episodes stopped on their own. Now she came back to the father's place around 2 weeks and started with the same complaints, including the abusive behavior and suicidal thoughts. And after some time, she started being happy. Then in past history, patient has taken treatment 4 to 6 months back. And since 3 days, she's taking treatment from private hospital. That is tablet amitriptyline 25 mg BD, olanzapine 7.5 mg BD, tablet divalproate 250 mg BD, and tablet trihexyphenidyl 2 mg HS. No history of any diabetes, hypertension, tuberculosis, bronchial asthma, IHD, allergy, head injury, seizures, and any past surgical history. Then in obstetric history, patient is 7-month ANC, G2A1, P0L0, LMP 16/8/2021, and EDD is 23 May 2022. Then family history is not significant. Personal history, decreased sleep, bowel bladder and appetite is normal, no history of any addictions. In general examination, patient is conscious, oriented to time plus person, averagely built, moderately nourished, General condition, pair febrile, pulse is 80 per minute, BP is 110/70, SpO2 is 99% on 2-mer, no pyloricterus, clubbing, cyanosis or lymphadenopathy. Breast, thyroid and spine is normal. Height is 5 foot 4 inch. Weight is 58 kg. On airway examination, no loose teeth. Mouth opening is 3 finger width. MPC grade 2. Adequate neck movements. Thyromental distance 7 centimeter. No congestion of oral mucosa and no tongue edema. Then on obstetric examination, on inspection, a globular swelling arising from the pelvis, linea nigra, strava gravidarum are seen, umbilicus is everted, no scars and sinuses. On palpation, uterine size is 28 weeks by McDonald rule, fetus is palatable. Leopold maneuvers are done. The first fundal grip, soft, broad, irregular mass suggestive of breech. Second is lateral grip, smooth curved resistant feel suggestive of fetal bag on right side. And on left side, small multiple knob-like structure suggestive of fetal limbs. Third is Paulica pelvic grip, smooth hard globular mass suggestive of fetal.
Okay. Sorry to interrupt. This is mainly for discussion on ECT.
ECT,
Because
okay.
it is given as a obstetric case, please don't dwell too much on that.
Okay.
And straight away go to the psychiatric problem and the ECT discussion. Okay.
Yes, so this is-
Forget about the obstetric problem, because the question has been worded with that obstetric also. This is mainly a short case scenario. So forget, she is not pregnant. She is a 32-year-old female with a history of psychiatric problem requiring ECT. How are you going to give anesthesia?
Okay, sir. First of all, I will take the pre-anesthetic check. I will do the pre-anesthetic checkup.
Okay. What are the points you want to find out in the pre-anesthetic examination?
So I will ask the history of any past history of MI or cerebrovascular accidents, which are the contraindications for ECT.
32-year-old, you think that she may have a past history of MI?
No, sir. But in this age, MI are common in 30-year age also. So and relative.
More than that, think of common things. My surgery unit chief used to tell us, think of common things, you are commonly right. Think of rare things, you are rarely right. Okay. So even though the MI is happening, I agree with you, even at 24, 30, but it's a rare incident. It doesn't happen every day in a 20, 30-year-old. Okay. So more than that, what is the important history you would like to know about the psychiatric problem? One important thing that you have to know, what the type of psychiatric problem, and which is the very, very dangerous thing for the patient.
Suicidal tendencies?
Suicidal, yes. Suicidal tendency. That's a very, very important. So you must know what is the psychiatric diagnosis, whether it is schizophrenia, whether it is severe depression, whether it is bipolar, whether it is maniac, whether it is suicidal tendency. Okay, so that is very, very important. What exactly is the diagnosis that they have made, and why they prefer to give ECT as a part of the treatment or a sole treatment? What is the mechanism? How does it help in curing the patient with a psychiatric illness?
When the patient are resistant to the psychiatric medications, so then ECT is preferred. And the mechanism is not known, like it is not known till date. But
whenever you do not know the exact mechanism, you will always postulate some theories, isn't it?
So there are some
always
theories.
In medicine, if you do not know the exact cause, I will say something and you will say something, and everybody will give their own postulation, and that will be the common discussion, isn't it? So what are the theories that are proposed to say?
Theories are related to, they increase the blood-brain barrier.
Increase the blood-brain barrier. What do you mean by that?
And second is like increase the cerebral blood flow. Then changes in neuroendocrine activity. These are some.
See, all the psychiatric drugs that are prescribed, what is their main mode of action? Most of them. What do they do exactly? You give tricyclic antidepressant, you give SSRIs.
Inhibit the reuptake of serotonin and
so they enhance the availability of neurotransmitters. In simple words, they enhance or make the neurotransmitter available more in plenty at the synaptic junctions. Okay, so that the transmission is much faster. It's supposed to be little less in the patients who are affected by psychiatric illness. So you want the transmitters to be available in plenty. So you give drugs to stimulate or make the transmitter. What are the common transmitters at the neuronal synaptic junctions? Norepinephrine and serotonin. Yeah, these are the two transmitters. So by giving an electric shock, what are you going to achieve? They say it will increase or enhance the availability of the neurotransmitter and make them work faster also. Okay, so that is the mechanism by which it is supposed to help the patient, improving the availability and transmission at the synaptic junctions to with the availability of transmitter substances. Okay, so how was electroconvulsive therapy given in the olden days?
Olden days, they are giving without anesthesia, sir.
Without anesthesia. That was called the electroconvulsive therapy unmodified.
Modified is with the general anesthesia.
Okay. So why they have to modify? What are the reasons for modifying the ECT which was given without any anesthesia in a fully conscious patient, just pinning him down on the ECT table and preventing him from jumping and giving the anesthesia? What is the reason? Why they have to change from that and modify that?
Multiple bone fractures.
It is first of all inhuman, no? See, when a patient is going to suffer with the convulsion after you apply the shock, you give that, it is almost like a torture. Okay, it is like in the movies you see somebody is not revealing something, especially the spies. They will give the shock and try to make them talk. Okay, to bring out the truth. So it is almost like that, like a torture. So first of all, it is inhuman. Second thing, it produces more contractions, violent contractions, which result in injuries to the patient, to the teeth, to the tongue, to the joints, muscle rupture. All these things have been reported. So because of these two reasons, they wanted to modify it and make the patient unconscious, sleep, and then induce this electric shock so that they can get the desired result. But what is the disadvantage in making the patient unconscious with an induction agent?
Disadvantages.
Supposing you suppress the brain by giving your induction agent, your tapentone or propofol,
Hypotension.
will you require more current to stimulate that brain or less current to stimulate?
Yes, sir. It will increase the seizure threshold.
It will increase the threshold, isn't it? So you have to strike a balance between the induction agent that you give and the current that you require to stimulate the. So they induced sleep dose of drugs they gave and maintained that threshold required for stimulating the seizure. But at the same time wanted to prevent a violent response also. So they added a muscle relaxant. Which muscle relaxant is given?
Succinylcholine.
Succinylcholine is given. Is it given in a full paralyzing dose for us?
No, sir. 0.5 to 1 mg per patient.
What do you call that dose? It is called a subparalytic dose. Patient will not be fully paralyzed and he will not become totally apneic, but the respiration will be depressed. Okay, so the contractions and the respiratory depth will be depressed, but he will not be totally paralyzed. So it is called a subparalytic dose of a dexamethasone is given. Have you ever given anesthesia for ECT?
Yes, sir.
Okay, so how do you do that? Tell me.
Sir, first we had a separate OT for ECT.
You have a separate OT for ECT or you give it in the psychiatric department side room or something
separate,
like
separate side room in the psychiatric ward. So we have an anesthesia machine and ambu bag and face mask.
So anyway, is it like a regular OT or is it like an aura procedure?
Nora procedure, sir.
It's a more or less NORA procedure in many of the hospitals because they don't bring the patients to regular OT and do this. So
Just
the
a
side
separate,
room that
side
will
room.
be maybe equipped but not like a regular OT. So first and foremost thing is ECT procedure. Majority of the time it's like a non-operative room anesthesia procedure, number one. Okay.
Yes,
So if it is a NORA procedure, what are the precautions you have to take?
sir.
Or what are the things you have to check before you give any
First, I
anesthesia?
will check the suction on anesthesia machines,
Hmm.
laryngoscope, ambu bag, oxygen's source like oxygen cylinders,
Hmm.
and resuscitative medications like adrenaline, atropine,
Very good.
glycophage should be ready.
Okay. Mm.
Then I will like for these patients we use a scalp pen
Mm.
for IV line.
Mm.
Then after taking IV line, I will give the injection glycopyrrolate 0.02 mg per kg.
Mm.
Then injection propofol
Mm.
1 mg per kg dose, like
Mm.
0.75 to 1 mg per kg dose. And
Mm.
then I will ventilate the patient for 3 minutes with 100% O2 by face mask and ambu.
Mm.
And then
When you have anesthesia machine, why do you require an ambu? Usually you will have
that
an
was
anesthesia.
a normal Boyle's machines.
Okay. Even Boyle's machine, if you have a face mask, you can ventilate the patient. No, after all, what you are going to do is only oxygenate the patient, not give any anesthesia or anything.
In
Okay.
our institute, we used to use the separate
Okay. Okay.
O2
Mm.
cylinder. And
Mm.
then after that, I will ventilate the patient for 3 minutes with 100% O2.
Mm.
After that, I will give injection schooling 0.5 to 1 mg per kg, like 25 to 50 milligram.
Mm.
Then after settling of fasciculations, I will
Mm.
hand over the patient to the psychiatrist for
Psychiatrist.
ECT.
Mm.
And before that, they will I will put the bite block to the patient.
Very good. Excellent. Mm.
Then I will hand over to the patient
Patient to that. Okay. Mm.
psychiatrist. And after the ECT,
Mm.
then I will resume with my face mask ventilation
Mm.
till the patient is settled on room air. That till the patient is settled with room air SpO2 99%.
Okay. Do you know the physiological responses to this shock?
Yes,
What
yes, sir.
happens?
First there is a parasympathetic response.
Mm.
Patient has bradycardia and
Mm.
hypotension for
Mm.
first 1 minute, and after 3 to 5
Is it
minutes,
1 minute? It's not 1 minute. It is seconds, hardly
seconds,
15 to 30 seconds.
15
Okay.
to 30 seconds, and after 3 to 5 minutes, patient has a sympathetic response. That is
Again, that is not
tachycardia
in
and
minutes.
hypertension.
Everything is in seconds only. Okay. First 15 to 30 seconds, you will have intense parasympathetic stimulation, followed by intense sympathetic stimulation for the next 30 to 60 seconds. Okay.
I see.
So the total thing, the response will be only maximum for 1 to 1.5 minutes maximum. Okay.
Okay.
So sympathetic response, how does it exhibit?
Tachycardia and hypertension, sir, means
Cardiac and hypertension. What are the muscular effects? What type of contractions you have?
generalized tonic-clonic seizures. Will be seen.
Tonic. So a parasympathetic tonic response and then clonic response will be there. So that is the time you can get all the injuries because of the violent muscle contractions. Okay. So that is how you have to take care of all these patients, right? What are the contraindications for ECT?
Contraindications are recent MI or CVA within 3 months and
Hmm.
phlebotomocytoma raised intracranial pressure. These are absolutely.
As the question was worded, if supposing the patient is pregnant and they also suffer from a severe psychiatric problem, can they have ECT during pregnancy?
Yes, sir. Means certain studies are done and they are saying that it is safe.
So there
in
is no
pregnancy.
absolute
No,
contraindication for giving ECT even in
pregnancy.
pregnancy. Very good. Okay.
But it requires obstetrician and neonatologist also
Okay.
because the chances of preterm labor.
So I will just try to, Kamashi, can I share the screen?
Please, sir.
Okay.
Visible, sir.
Is it visible now?
Yes, sir.
Okay. So this is it visible?
Yes, sir.
Okay. So this is the thing for anesthesia. What is ECT? It's electroconvulsive therapy, is a treatment for severe depression and psychiatric condition not responding to drug therapy or used as a adjuvant to pharmacological therapy. It involves passing an electric current across the skull to induce a grand mal seizure. So you purposely induce a grand mal seizure. So that will raise the question, can a epileptic patient undergo ECT?
Epileptic patient.
You are now purposely inducing an epilepsy-like feature in a patient as a treatment. Supposing already patient knows himself is an epileptic and he has a psychiatric problem also, can he undergo ECT therapy?
Mhm.
Definitely he can, no problem. Okay, so there is no contraindication for giving ECT therapy in an epileptic patient. So the electrodes are usually applied what is called the bitemporal electrode. Usually you apply it on both sides of the temple, and so this is the electrode position where you have to apply just about the temporal region. And there is a unilateral. So this is called bilateral method of applying the electrode. Whereas unilateral, supposing there is some implant like a cochlear implant or other electromagnetic things that are implanted in the skull, then you cannot give the shock on that side. So you do what is called unilateral stimulation, where the second electrode is placed in the midline within this arc 18 centimeters from that, and the first electrode is placed in the temple, whereas bilateral you place it directly on these things. So this is how the placement will look like. This is bilateral, this is unilateral. And what is the type of the current that is used? It is an alternating current delivered as a pulsatile square wave form, and the strength of the current is 500 to 850 milliamperes delivered through electrodes applied to the locations that have been shown in the head. The energy used is about 30 to 45 joules and given for 0.5 to 1.5 seconds. So that the whole duration of the current will be only for 0.5 to 1.5 seconds. And what physiological changes take place during ECT is the CNS, there is a grand mal seizure, starts with a short latent phase followed by a tonic phase for 15 seconds, followed by a long clonic phase for about 30 to 60 seconds. So it is never in a large number of minutes, it is always in seconds. And there is a generalized skeletal muscle contraction during the tonic phase. And EEG seizure activity continues even after cessation of motor seizure activity. And there is a post-ictal phase with confusion and agitation. So the increase in cerebral blood flow, intracranial and intraocular pressures, all these things can happen. So anybody with a raised intracranial pressure or glaucoma, it is a contraindication. You cannot give the shock to them. And it also increases the cerebral oxygen consumption. And in the CVS, there is an initial parasympathetic overactivity which may cause bradycardia, hypotension, and even sometimes asystole. And this is followed by a sympathetic discharge during the clonic phase with intense adrenaline levels, which may increase 15 times on noradrenaline level up to 3 times more than the normal. Okay. So that is why any cardiac patient should not have this therapy done. And this may result in tachycardia, hypertension, and arrhythmia, or increase myocardial oxygen consumption and demand. In the gastrointestinal, there may be salivation, raised intragastric pressure, nausea, and vomiting. And musculoskeletal, possibility of muscle and bone injury. Jaw muscles are stimulated directly, resulting in clenching of the jaw with possible injury to teeth and tongue. And that is why putting a bite block is very, very important to prevent injury to the teeth. So how does ECT work? What is the mechanism? ECT causes chemical and cellular changes in the brain that relieve severe depression by improving neurotransmission. So the transmitters are improved. So mode of action can be attributed to acute amnesic change in the patient. Patient may have forgotten about what is bothering them because of this amnesia. And the biological mechanisms are divided into neurochemical, neuroendocrine, and neurophysiological. So the neurochemical investigations have shown that the role of catecholamines, especially in norepinephrine, is a presynaptic and postsynaptic transmitter, and that may be because of the improved neurotransmission, and physiological because of the cerebral hypometabolism that happens because of the ECT, and endocrine polypeptides from hypothalamus change the neuroendocrine activity and affect the thalamocortical pathways. So there are three mechanisms: neurochemical, neuroendocrine, and neurophysiological. And the persistent behavioral or therapeutic effect changes in the CNS are due to repeated ECT seizures that not changes the actual vascular or the structural components are not altered. They alter only the function, but not the histology or anatomy of the brain. That is very important. So how do you assess whether the patient is getting improved by the ECT? Is the patient eating well, gaining weight, and having a good appetite, good sleep, and increased libido, and increased interest in the environment. So their whole mood changes. They become more sociable. You can see less depression in them. So all these things indicate that they are improving with the treatment. And the pre-op assessment, detailed history and physical examination. Patient sometimes may be very elderly also with lot of comorbidities which should be evaluated. And in the CVS, look for IST, hypertension, what is their effort tolerance, and any angina medications are being taken by the patient. CNS, whether any previous CVA, cerebrovascular accidents, or any intracranial lesions or raised ICP is present, you should evaluate. Musculoskeletal, look for osteoporosis or muscle disorders. GIT, whether they have any gastroesophageal reflux or hiatus hernia. And eye glaucoma. All these things are very important contraindications. And psychological conditions, like severe depression, bipolar, or mania, or suicidal tendency, that is also you should be aware. And what are the medications the patients are taking like SSRIs, MO inhibitors, or lithium, and history of previous ECT and how many times it has been given, what was the behavior or the procedure, how did it go without any complications. And dentition should be thoroughly examined. If the patient has got any loose tooth or an artificial denture, you must take proper care of that, otherwise likely to be damaged. And any allergy to any drugs also should be documented. Then clear pre-op instructions like fasting. This requires fasting. Unlike your cataract surgery done under local anesthesia, ECT, because you are going to make the patient unconscious, strict fasting guidelines is very important. You have to stop the anticonvulsant drugs. If the patient is a known epileptic, you have to withhold the anti-epileptic medication. And some of the drugs like MAO inhibitors, tricyclic antidepressants, all the psychiatric drugs also you withhold on the day of the ECT. And who found out this treatment is two Italian neuropsychiatrists, Lucio Bini and Ugo Cerletti. They are the first ones who used this. They used it for schizophrenia and then later found that it is not useful for schizophrenia. It is only important for depression. And then they introduced what is called the modified use ECT. Unmodified was given earlier in a conscious patient. In 1960, they modified it using anesthesia and muscle relaxant. So not generally considered for treatment of schizophrenia, but later on modified for other treatments. It is to be given as a course. It cannot just stop with one ECT. It may have to be given at least weekly, twice, or at least 6 to 10 sittings have to be given. And it is usually administered in the bilaterally. That is both the temples, it is placed over the bones, and then unilaterally in the non-dominant hemisphere if there are concerns about post-ictal confusion. So ECT may be given to patients with epilepsy, but treatment with anticonvulsant may increase the baseline seizure threshold. So that is why you stop the anti-epileptic medications on the day. And other relative contraindications, if there is an MI within the last 3 months or patient has unstable angina, if there has been a CVA within the last 3 months, raised ICP or untreated cerebral aneurysm, unstable major fracture or cervical spine injury, pheochromocytoma. The patient has got that endocrine problem. During the second phase, when the parasympathetic system gets stimulated, patient may develop alarmingly high BP. And uncontrolled cardiac failure or valvular diseases or DVT patients. So cochlear or other brain implants pose the technical challenge of giving bilateral ECT. So you have to go for unilateral ECT in those patients. And it can be safely given if the patient has a pacemaker also, because you are far away from the pacemaker, so there is no worry. But if it is an implantable cardioverter defibrillator, you have to revert the anti-tachycardia function. And electroconvulsive therapy can be used in pregnancy also. So how do you do that? Most of the time it's a NORA procedure. So all precautions pertaining to it must be adhered to. Anesthesia is a short duration for ECT procedure, short duration. So patient should be able to recover and go home. The aim is to provide short duration unconsciousness and adequate muscle relaxation. Return of consciousness should be rapid and full orientation is desirable. So how do you commonly give that? These are the medications that can be used. All the induction agents like ketamine, etomidate, methotrexate, propofol, all have been used. But ketamine is used in a very smaller dose, and but it may increase the sympathetic discharge. So that is not ideal if a patient is already hypertensive. And propofol and muscle relaxants, suxamethonium is the commonly used, but in the absence or if there is any contraindication for that, you can use rocuronium also in a smaller dosage if suxa is contraindicated. Now, can you identify what is this instrument? What does it look like? It is the bite block with a airway, which is used for this ECT procedures. So this portion will go between the teeth, and this will cover the lips. And this knob you can attach oxygen and give oxygen therapy. There is another picture which will show how exactly it has been used. So this is oral protector to prevent the tongue biting or tooth fracture during seizure. So who are all the people who are required for an ECT team? That is, electroconvulsive therapy is not a single person like an anesthetist and surgeon alone. Which team forms that? So psychiatrists, anesthetists, trained nurses, nursing aides, and ECT assistants. So all these people are involved in that. And what equipments are needed for giving anesthesia for ECT? So you need articles for anesthesia, suction apparatus, face mask, oxygen cylinder, tongue depressor or bite block, and full set of emergency drugs, ECT. This is what I asked in the beginning. If it is a NORA procedure, you have to remember it by the mnemonic SOAP, SOAP me. So suction, anesthesia equipment, oxygen, okay, pharmacy, all those things are given in that. And if supposing the present day COVID patient, if he is also a psychiatric patient, if he is coming for ECT, what are the preoperative considerations you have to know? First thing is you have to make a proper patient selection. So each patient should be tested for SARS-CoV, and if they are positive, you have to wait for 14 days after subsequent negative test. So there is no urgency to give a ECT for a COVID positive patient. And if it is a symptomatic SARS-CoV positive patient, no ECT, no, not to be given at all. But if the patient is tested positive, but he is asymptomatic, you wait for 14 days, get a negative result, and then you can give an ECT. But if the patient is symptomatic with lung involvement, CT findings positive, then no ECT at all for that patient. So either you give after a negative result in an asymptomatic patient, or you don't give at all if the patient is symptomatic and positive, tested positive. Now coming to the airway management for this patient, positive pressure mask ventilation. So normally we do that, as the Preeti also was telling. After induction, you ventilate him for 3 minutes and then give the relaxant and hand over to the psychiatrist. So this practice may be causing virus aerosol generation. So you have to just allow the patient to keep breathing normally without any positive pressure ventilation or induce any cough. So minimize positive pressure ventilation, minimizing masking strategies, avoid hyperventilation, consider a glycopyrrolate if there is a chance of salivation or cough. Consider antitussive strategies like remifentanil or lidocaine, and then utilize negative pressure room if it is possible. And during recovery, recover the patient designated areas with the patient face covered with a surgical mask. Allow 30 minutes between two patients to be shifted in and do the procedure. So these are all the guidelines that are given for COVID positive patients in who are coming for ECT. Now, what does this picture show? You can see the instrument I showed you, how it has been inserted in his mouth. So what do you think, this type of ECT, modified or unmodified?
Unmodified.
Unmodified. Why so much of time? See, patient is wincing, so he is feeling that shock, and so it is unmodified. On the contrary, this is it modified or unmodified?
Modified.
Modified. So patient is happily sleeping. The psychiatrist is holding the paddles, and you can see this is a different color, but the same type of bite block. Okay, so the same thing in a different color and more sophisticated. So the key points are ECT is usually administered at remote locations. Modified ECT uses anesthesia and muscle relaxants and recommended standard practice. Full anesthetic assessment with attention to aspiration risk is essential. Adequately trained staff and appropriately equipped unit is imperative in creating a safe practicing moment. So when the patient comes for the first time, you must do a full anesthetic assessment with particular attention to aspiration risk also, and make an look out for the dentition. It's very, very important because the risk of damage to teeth is very important. Or when the patient comes with the repeated times, review the old charts and see, because if the same person is giving, no problem. But if different anesthetists are coming to give for the same patient, then you have to go through the old chart and see the medications, whether they have been increased or decreased, and how he behaved during the last time. All these things you have to go. Look for the consent and vital parameters and fasting status before you give anesthesia. Intravenous access with full monitoring is to be achieved. Pre-oxygenation is commenced and an anticholinergic is administered. And anesthesia-induced muscle relaxant administered when verbal communication is lost. So you keep talking to the patient, and once he stops answering to your question, then you just hand over the patient. Gentle assisted ventilation is commenced, and if the fasciculations are stopped, then you have to put a bite block, and the EEG electrodes are applied to the patient's head and paddles are placed on the temporal region. Anesthetic stands clear and electrical current is applied. So during the time of applying the current, nobody should be touching the patient. The patient is evaluated for tonic-clonic seizures, which is documented. The bite block is removed when the seizure activity has stopped. Until such time, it should be in place. Airway support should continue after the patient has stopped the seizures and transferred to recovery room once spontaneous ventilation has returned and it is sufficient and is maintaining saturation normally in room air. Until such time, you have to take care of the patient. A warm drink or light meal is offered to the patient when appropriate. So within about half an hour to 45 minutes, when the patient is fully awake, you can offer them something to drink or eat because they have not had any more severe inhalation anesthetic or anything like that. So this is the anesthesia for cataract surgery. When the lens of the eye, which is normally clear, becomes opaque, this is called cataract, which is the meaning of waterfall. Leads to a decline in the amount of light entering the through them. So normally lens consists of natural crystalline material that is combined in specific quantities with proteins and water to form a transparent structure that allows light to pass through. Therefore, the occurrence of cataract will lead to a vision that is similar to looking through a paper or a waterfall. Okay. So what is the lens anatomy and physiology? So the lens consists of a lens capsule, subcapsular epithelium, lens fibers. It does not contain blood vessels or nerves. So this is the histology. Glucose is the main source of energy used by these fibers to grow and become transparent. Aerobic reactions are responsible for only 30% of ATP production in the lens and over 70% come from anaerobic glycolysis. Ion channels conducting the calcium ATPase or potassium, sodium potassium ATPase work to maintain homeostatic environment in the lens. Most important molecule that works in the lens is an antioxidant which is synthesized and secreted by the epithelium and directly protecting the eye from oxidation. Avascularity of the fibers and the thin interfiber spaces and the regular organization of protein and cells are the main factors on which transparency is dependent on. So within the fibers themselves, crystallines are present in short ranges which are shorter than light wavelength. So similar to glass, that is why it is able to transmit the light. So factors which maintain the transparency of the lens is a thin epithelium, that is the subcapsular epithelium, regular arrangement of lens fibers, little cellular organelles, little extracellular spaces, orderly arrangement of the lens proteins, relative dehydration, semi-permeable character of lens capsule, avascularity and antioxidants. So this is how a normal eye looks and this is a cataract eye. You can see that the entire thing is now become opaque. This is quite transparent. Healthy lens allows for all parts of the retina to receive the image. Whereas clouding of the lens in the eye that affects vision, a cloudy lens scattering light. So light gets scattered, doesn't fall on one particular part on the retina. And the crystalline lens is biconvex and transparent. It is suspended by the zonules arising from the ciliary process, extending centrally to attach to the equator of the lens. Lens is surrounded by elastic capsule, which is basement membrane secreted by the lens epithelium. There is an anterior lens epithelium. Lens fibers arise from the epithelium at the equator. So changes in the physical behavior with age. Increased scattering of light is a result of continuous series of reactions biochemical leading to stiffness and even coloration of the lens. These changes affect the nucleus more significantly than the cortex and they are the main reasons for the loss of accommodation. As the age processes in the absence of cataract, overall scattering of light increases steadily and especially after the age of 40, these changes start occurring. They decrease in elasticity also. So the accommodative power also is reduced. So this increases result thickness and changes of the lens. The curvature is not uttered. So that is why they are not able to have a clear focus on the object. So 90% increase in the thickness of lens was caused by thickening of the nucleus of the lens. So changes in stiffness and elasticity are progressive and changes in the protein concentration also happen. Other contributing factors are changes in the lens protein with age. So post-translational changes to the lens crystalline, conformational changes, loss of chaperone function, loss of antioxidant free radical scavenging capacity. So types of cataract, it can be nuclear cataract, it can be cortical cataract, or it can be posterior capsular cataract. These are the three types. And what you see in this picture, they're all pictures seen through the slit lamp. Normally, by just throwing the light, you cannot see this. So in the nuclear cataract, you find there is a central color change, whereas a cortical cataract mostly in the periphery, and posterior subcapsular look are darker, just like a nuclear, but it is on the little posterior side. And so this is how, this is a broader picture to show where all it can happen. So this is the central portion nuclear cataract. This is the posterior capsular cataract, and this is the cortical cataract. So the cortex has got an outer cortex and an inner cortex. So this conjunction between both outer and inner called the cortical cataract. The cortex which is affected more on the posterior side is called the posterior subcapsular cataract. So the intracapsular surgery was done in the earlier days with a larger incision where they removed the entire lens. So this was the older technique of doing it, removing the entire mature lens, and you will still be seeing some old people in the villages with the thick glasses like that. So there is no intraocular lens placed in these cases. They remove the entire lens, and then standard they give a 10 diopter lens for all of these things. So if it is an extracapsular, what you do is you make an incision on the anterior capsule, expel the nucleus, and then you clean up the posterior capsule, and then if you want, you can insert a lens also. So that the same thing is done by phacoemulsification, and these are all the steps in phacoemulsification. You make an incision, make a rent in the capsule, break all this material and suck it out, and then this is the lens which has been folded and inside placed in the posterior capsule is still there. So you place it there, it will automatically get hinged there and remain in place. So these are all the steps of the phacoemulsion. So it's a daycare procedure. Most patients are elderly. Conditions like hypertension, diabetes, IHT, COPD, musculoskeletal, Parkinson's, especially, that is neurological problem also. And patients with BHP, what is the problem there? If they come for cataract, supposing they have not undergone a TURP, they are on medication for benign hypertrophy of the prostate. Which medication can interfere with the surgery? The tamsulosin that you give, it produces a condition called floppy iris syndrome, which is a condition where the pupil will not dilate properly, micropupil. That will cause a lot of difficulty for the surgeon. So the patient may be on multiple medications like anticoagulant, antiplatelet, antihypertensive, OHA, antiparkinsonism, and this drug, tamsulosin for BHP, is also a very important history. Surgery if you are doing it under regional technique, but regarding the, if a diabetic patient coming for surgery, you can ask them to omit the OHA, because in case there is a delay or there is a change of timing, then patient should not become hypoglycemic. So axial length of the eye should be checked before peribulbar block to prevent globe perforation. The normal value is less than 26 millimeter. Ascertain history of previous cataract surgery, whether the other eye has already been operated, what type of anesthesia and any problem has been taken and encountered. No pre-med is normally administered except in very anxious ones, but usually acetazolamide, a Diamox, is given for the reduction of intraocular pressure. Intraoperative conditions, considerations are usually done under local anesthesia, either using topical or infiltration as a retrobulbar, peribulbar, or a parabulbar. This parabulbar is the tenons, and it can be intracameral also. That is, after you make an incision in the cornea, you can inject local anesthetic into the anterior chamber. Sometimes combined with facial block. In the olden days, they used to always combine with facial block to prevent the squeezing of the eye by the lids. So they wanted to paralyze the lids also for easy relaxation and retraction of the placing the speculum. And standard monitors like EKG, NIBP, oxygen saturation are used. Supplemental oxygen may be given under the facial drapes if the patient has any issues of oxygenation. Maintain communication while doing the surgery. Avoid hypothermia because that will make the patient shiver, especially older patients. And atropine should be kept ready for any bradycardia due to oculocardiac reflex. And GA may be needed in children or uncooperative anxious adults where patients are dementic or LA allergy, clotting defects, severe myopia. In all these cases, GA may be required. And the technique of giving GA is IV induction, non-depolarizing muscle block, muscle relaxant, ET tube intubation with a cuff to oral ray tube or a flexometallic LMA, controlled ventilation with oxygen. Air will be better. Nitrous oxide can stimulate vomiting. So volatile anesthetic agent and analgesic plus block or topical. Reversal, smooth extubation to avoid bucking and coughing. So these are all the steps of GA. And post-op oral feeds, medicines are allowed. Simple oral analgesic like paracetamol is more than enough. And anesthetic techniques, disadvantages and advantages. Types of anesthesia can be local, general, surface or regional. And these are all the various drugs that are used. See, commonly used is this proparacaine, is the drug which is topically applied to the ophthalmologist. Even though we say lignocaine, bupivacaine, ropivacaine, all these things, this proparacaine is the commonly used drug in most of the centers. And the nerve blocks can be peribulbar, retrobulbar, parabulbar, intracameral, facial, and frontal blocks. And surgery, again, these are all repetition of that. Entitles very low risk, easy to perform, and low intraocular pressure will be there. So economical, all these things are the advantages of regional technique. This is the technique of doing retrobulbar, where you just go at the lower border of the orbit, at the little medial to the lateral canthus, and then use a small 22 gauge needle, 3.5 centimeters long, and this has to be placed inside the cone. So this is also known as intraconal block. Peribulbar is the extraconal block where you give about 5 ml of bupivacaine or 5 ml of 2% lignocaine. Hyaluronidase is also added. So this picture tells you the difference between these two techniques. So retrobulbar or intracoronal is the injection into the cone formed by the four muscles, whereas the peribulbar is outside the cone. But the point of entry is same for both. This is the medial canthus, this is the lateral canthus. So just about 1 centimeter medial to the lateral canthus, abutting the lower border of the orbit. The bone you have to palpate and go. So the complications are, it can produce chemosis, periorbital ecchymosis, and penetration of globe, staphyloma, oculocardiac reflex, retrobulbar hemorrhage, inadvertent or intravascular or anaphylactic shock, or it can be subdural injection also is possible with retrobulbar. What are the nerves that are anesthetized? Are the ciliary nerves, ciliary ganglion, third and sixth cranial nerves. All these things are blocked by retrobulbar, whereas the complications are much higher. As I told earlier, the same thing, retrobulbar hemorrhage, globe penetration, and this is the parabulbar or subtenon block. which is given by the mostly surgeons themselves after they make an incision at the infromedial limbus or conjunctiva. Use a blunt cannula and insert it into that and inject about 1.5 to 2 ml. So this is the histological layers. So this is the cornea, this is the sclera, this is the subtenon space. So this is a conjunctiva which is covering. You make a small incision and then introduce. You can see the bluish color thing, which is the subtenon space extending all through the globe, all surrounding all part of the globe. So if you inject it, it will spread through the entire place and then produce a nice analgesia there. So intracameral is by injecting into the subtenons area. So you produce there and inject the drug. So these are all the facial blocks that were used once upon a time to block the eyelids so that they don't close the eyelid and it can be easy to apply the speculum. So 3 locations where they can block. One is called the Natboth block, where it is blocked from its emergence at the stylomastoid foramen itself. Then there is a O'Brien block given in front of the tragus on the face. The third one is the modified Von Lint block given near the zygoma. So all these things are not nowadays practiced, but in case you answer very well and the examiner wants to give you high marks, you can ask all these things. So intraoperative floppy iris syndrome is a variant of small pupil syndrome. It has been observed during cataract surgery in some patients using previously treated with the alpha adrenoreceptor blocker like tamsulosin. Then scleral buckling done for retinal detachment. Sometimes, instead of asking the same thing about cataract, suddenly if they change over to retinal detachment, the problems in anesthesia for retinal detachment, it is usually done in darkness because they use focusing light and do it, and long duration, so mostly done under GA. You have to avoid nitrous oxide because they may use a hexafluorine bubble to cause the tamponade. You have to avoid hypercarbia to prevent rise in IOP, and subtenons block for the first time can be given, but if it is a repeat procedure, then you have to go for peribulbar block because that will be sclerosing and scarring will take place. So these are all the things that I just wanted to share with you with regard to these 2 topics. Shall we go for the Viva questions? Kamachi?
Sir,
Or shall we already 2 hours?
already, yes, sir. Yes, sir.
Yeah, shall we
Sir,
have it for the next class?
yes, sir. Friday we can have, sir.
Yeah, okay. Any doubts or any questions on this for anybody who wants to have that?
Any questions from the students, please?
I think everybody is happy with this. Okay. See, you should develop some habit of noting down some questions and doubts and then talk freely in the forum. Okay. Then only it will be interesting. And I am not able to see your faces, so I am not able to understand whether anything has gone into or there's been a monologue talking to myself. Okay.
Yes, we are uploading the videos in the YouTube channel also. If the students are able to give their comments or questions in the YouTube channel, even that will be useful for other students.
Okay. Right. So shall we close?
Yes, sir. Thank you, sir. I once again thank our respected Professor Nagsami, sir, and I congratulate all the participating students. We'll look forward to the best next session on Friday also. Thank you, sir.
Thank you very much.